This PowerPoint is going to focus on cellular regulation, and it's going to be an overview of cancer. So we're going to focus on cancer in general and not any specific types of cancer. We'll talk about different types just to use them as examples to help relate the material, but we'll go more in depth on specific types of cancer at later points this semester and then next year. So because this is the first content that you've really had that involves the concept of cellular regulation, just a quick little bit about what cellular regulation actually means. Essentially, we'll just take the word apart. We're talking about the regulation of our cells within the body. So different topics that we'll discuss under the concept of cellular reg throughout the curriculum are going to be disease processes that control the function and the growth of the cells within the body. It could be something that affects the division of the cells or the differentiation or the purpose of the cells. And then we look at normal versus impaired. So primarily for cellular regulation content, we're going to talk about cancer and the different types of cancers. You'll also learn about anemia because it is an alteration in cells, specifically the red blood cells. And you'll also talk about sickle cell anemia at a later point in the program. And again, it's about a differentiation in the cells. So an interrelated concept of cellular regulation, it's going to be closely tied to immunity. So you may hear things that we talk about that relate the cellular reg to the immunity content that you've learned about as well. So the next couple slides are just terminology for you to review. I've made a Quizlet and it'll be posted to your course. It's optional, but it has the different terms and it has some other study material for this unit in it. You're not going to necessarily need to know the exact definition of it for testing purposes. Like, I'm not going to ask you to define a term. It's more when you have the stem of the question and some of these terms are used, are you going to be able to adequately answer the question if you don't know what the words mean? So there's 3 slides that have various terms on them for you to review. If you have any question about any of these, then just let me know. Okay, so a little review on some basic cellular regulation. This section pretty much comes from chapter 19 in your med-surg textbook. This table is very similar to a table that is in your textbook near the beginning of chapter 19 on page 365. It's just a differentiation of a normal cells versus a benign cell versus a malignant. So different aspects of cellular regulation that we look at are the division of the cells. So a normal cell either doesn't divide, depending on the type of cell that it is, or it divides slowly at a regulated pace like it should for whatever its function is within the body. It's going to vary based on the type of cell that it is within the body, but it has a process of cell division. When you have benign tumors that grow, the division of those cells is just continual. It doesn't stop, and the cells stay like their parent cell or like that initial one. They just continually divide, and that's what causes a benign tumor to form. With a malignant cell or a malignant tumor, that division is rapid and continuous. So the cells divide very quickly, which is important in relation to some of the treatments that we talk about and some of the side effects. And the malignant cells continuously divide. The morphology of a cell is basically what it looks like, the appearance of the cell. A normal cell has a distinct appearance, like that we know that this is a cell from the GI tract, or we know that this is a cardiac cell. Whatever type of cell it is within the body, it has a distinct appearance. Benign tumors those cells have a distinct appearance because they're very much like a normal cell. They're just growing and dividing to have more of them. A malignant cell doesn't look anything like, or it can progress to the point where it doesn't look anything like the original cell that it started out from. The functions of the cells, so normal cells have a function. Every cell that's in our body has a purpose. Benign have a purpose because they're very much like that normal cell. Malignant cells lose their purpose. When the DNA in the cell starts to change, then they lose their purpose and their function. So they're just continuously being made and they have no function. Normal cells tend to, so the next couple things kind of go together. The normal cells tend to stick together. So whatever type of cell it is, if it's a cell like within the lining of the GI tract, when it duplicates itself, it sticks together. It stays with other cells that are like it. So with a benign cell, same thing happens. It sticks together. And because they stick together, they are in close contact with each other. So that normal cell, it duplicates itself. It sticks to all of its little friends that are cells just like it. And once it touches enough other cells, it stops division. Well, with a benign cell, that part of that works and part of it doesn't. The benign cells do stick together, so they form like a benign tumor in the area where they started out, but that growth is overregulated and they don't really care if they're not touching other cells. That's how the tumor forms, because it continuously divides. That division doesn't stop just because it's surrounded by other cells. And then with a malignant cell, they don't stick together, which is how metastases can occur or spreading of cancer, because those cells kind of roam free. They can migrate within the body. They are not stuck together, so it doesn't have to stay with its friends that are like it. It can float wherever within the body, and that growth becomes out of control, and it doesn't care what it's in contact with. So spreading malignant cells or malignant tumors, cancer, can spread throughout the body. There are three primary modes for it to be able to spread, known as metastases. It can either invade the surrounding tissue. So based on where the tumor starts, it can start to spread just by direct contact into whatever is surrounding it. It can spread through the blood vessels. So the lymphatic system, the blood vessels, get pores in them, which allow the cancer cells to get into the bloodstream and then spread via the blood vessels. Lymphatic spread occurs with tumors that are close to lymph nodes within the body. One of the big examples we talk about is going to be breast cancer later on, but there's a lot of lymph nodes in the axillary area. So that's an easy mode for breast cancer to spread, that those cells get into the lymphatic system and spread to other sites within the body. With metastatic disease, the cells that travel are wherever they came from. So if it is breast cancer, then those cells started in the breast. If they spread via, we'll say, the lymphatic system, and they spread to the brain. So the patient has metastatic disease in the brain, but it is breast cancer that has metastasized to the brain. They don't now have brain cancer or a new type of cancer. If it's metastatic disease, then it's those same original cells that have just spread within the body. So let's talk about a few things that can cause cancer. If you're a smoker, then this is one of the reasons why you should quit. Tobacco smoking is the highest risk factor for cancer, modifiable risk factor. Not just lung cancer. A lot of times we think that with smoking that our big risk is for lung cancer. There's also a high risk for oral cancer or bladder cancer due to tobacco smoking. So a few other modifiable risk factors, excess body weight, which will kind of directly link to the diet, and then the physical inactivity. Sedentary lifestyle, poor diet leads to excess body weight. So combine all of them and that risk is higher. Alcohol use, ultraviolet light, so sun, skin cancer, we tend to think a lot about with. And then cancer causing pathogens. So there are some viruses that are linked to cancer. The easiest example to usually remember for that is like HPV is linked to cervical cancer and is a known risk factor for it. The cells within the body that normally divide are more susceptible to cancers. So cells like bone marrow, which would be like your leukemias, skin cells, the lining of the GI tract, the ducts of the breast, and the lining of the lungs are common sites because those cells tend to be more susceptible to some of these risk factors that cause cancer. Interesting fact, it was estimated for 2020 that there would be 1.8 million new diagnoses of cancer in the US and over 600,000, so essentially like a third of that, deaths associated with cancer. So one of the big things is going to be prevention, which we'll talk about in just a minute. Another risk factor for cancers is genetics. Having a strong family history increases the risk for a variety of different types of cancers. There is genetic testing available so that patients can find out about some of their risk. Just because they do test positive for a specific gene doesn't necessarily mean they're going to develop the cancer. It means they're higher risk to develop it. A couple of the things that play into genetic testing is cost. It can be very costly to be genetically tested for certain genes related to cancer. The recommendations, which this is talked about in your med-surg book, those last 5 bullets are basically the people that are high risk and that genetic testing would be most warranted for. So if you have a patient who has multiple family members, and when they say multiple family members, they usually mean first degree relatives that have had a diagnosis of cancer. If there's groupings of similar cancers, like a mother had breast cancer and a daughter had breast cancer, then the granddaughter is going to be very high risk for it. There's also similar cancers in the fact that we know certain cancers are genetic or are linked together. For example, some of the breast cancers, colon cancers, ovarian cancers, like when they do screening and they ask questions, if there's a family history of one of those, then they typically will ask about other risk factors related to them all because they all seem to be linked together. Patients that have a family history of rare cancers are something that's relatively rare is more likely to have a genetic link to it. Patients who have cancer that was diagnosed at a younger age are more likely to have a genetic link. Again, breast cancer is an easy example. Typically, breast cancer occurs in older women. That's why we don't screen for it until 40s to 50s. That if you have somebody that's a younger age, so they develop it at 20 or 30, then they're more likely to have a genetic link to it. So they might be better, somebody better suited for genetic testing. Or if there's bilateral, so if breast cancer occurs bilaterally, if lung cancer occurs bilaterally, or renal cancer, some examples, that if it's occurs in both sides of an organ, then there's more likely a genetic link to it. Some of the genetic testing companies do offer a service that if a patient is diagnosed with a cancer and they are high risk, or they are tested for a gene, that they will offer genetic testing to first degree relatives at a reduced rate. So that does tend to make it more affordable. Most of the time, insurance doesn't tend to pay for genetic testing, so that's why the cost factor tends to come into play for a lot of patients. So some primary prevention strategies. So primary prevention is stuff that we can either avoid or we can change the behavior. So it's essentially all of those risk factors that were on that slide a minute ago. Don't smoke, healthy weight, activity, diet, alcohol, and then looking at your risks in your family based on your family history and your own history. So the other thing as part of primary prevention, this can also be where if something is found that could be considered precancerous, that they go ahead and remove it beforehand. Colon polyps is probably an easy example of that to remember, that colon polyps in themselves are not necessarily cancerous. They're a benign growth. However, if a patient has enough colon polyps, or if they stay long enough, then they significantly increase the risk of colon cancer. So by removing those polyps, we're therefore doing a primary prevention for colon cancer. The other type of screening of prevention strategy is secondary prevention. So secondary prevention involves the stuff that we screen for. So these are the types of cancers, and there's primarily 6 that are routinely screened for in most of the general population. So with screening recommendations, so there are a variety of screening recommendations put out and updated from the U.S. Preventative Task Force, from the World Health Organization, from the American Cancer Society, and the National Cancer Institute. And they are not all exactly the same. So some of them have different age ranges where they recommend stuff. Some of them start a couple years earlier than others. So there's a little bit of differentiation in some screening guidelines. So do you need to memorize all of the screening guidelines? No, they're going to change. It's more looking at what cancers do we provide education to patients on about screening. That breast cancer, cervical cancer, colon cancer, prostate, endometrial, and lung cancer are the 6 cancers that we typically have screening for. If you click on this link at the bottom of this slide, it links to the American Cancer Society screening guidelines, just so you can have an idea of what they look like. For example, like with breast cancer, usually around 40, 45, depending on which recommendation you're looking at, they start doing routine mammograms. For colon cancer, every adult over 50 should have a colonoscopy done. So it's more about the education aspect of it, and as nurses, educating the patients, following up. Like if you're doing an admission history on a patient, then have they had their routine screenings? Do they need more information about them? Though that's more the focus for the screening aspect of it. Who's high risk? Who needs to be screened for these cancers? So with most all of those cancers that I mentioned, those 6, there's recommendations for most of the general population. Some of them have more specific criteria that they recommend screening on. And as we talk about each one of those cancers, we go more in depth on in a later course. So we'll talk specifically about recommendations for those patients. some general warning signs of cancer. So some cancers are found on routine screening. Others, patients come in with a symptom or one of these early warning signs. So these are some common things that if a patient comes in and you're doing your intake assessment or history and they report some of these, then just keep that in the back of your mind. Just because they have it doesn't necessarily mean that they have cancer, but that these are often some of the first signs or symptoms that we see. The acronym CAUTION is just to help you to remember them. Change in bowel or bladder, so looking at GI or GU related cancers. Lesions that don't heal, could be like a skin cancer. Unusual bleeding or discharge could be related to a reproductive cancer. Thickening or a lump in the breast would be breast cancer. Indigestion, difficulty swallowing, could be esophageal. A change in a wart or a mole, skin cancer. And then a nagging cough or persistent hoarseness is lung cancer. Some other questions that we typically ask about on general admission assessment: has the patient had a significant weight loss? We usually say about 10 pounds. Non-intentional, like not a patient that's trying to lose weight, that the patient has just suddenly started losing weight over the past few weeks. Are they reporting new pain somewhere or fatigue? So it's really more about the assessment, just to try to see if a patient is maybe having warning signs of cancer. So diagnosis of cancer. So diagnosis is made with a biopsy. The only definitive way to know it's cancer is to actually look at the cells and make sure. So there's a variety of different types of biopsies that can be done, and they're on the next slide, so we'll talk about those in just a minute. Some of the other things that can be looked at. So tumor markers. So tumor markers are substances. They can be either genetic changes or they can be proteins that are made by the body or made by the cancer cells themselves. They can be used to aid in diagnosis. There is a giant list of possible tumor markers. And they are linked, most of them are linked to a variety of different types of cancers. So you can't just look at the tumor marker and that automatically makes a diagnosis of a specific cancer. It can increase the probability of it. It can see if you're more high risk for it, but it aids in the diagnostic procedure. It's not the definitive diagnosis. It also, sometimes the tumor markers are looked at as far as prognosis and staging of cancer, or to look at the likelihood of reoccurrence of certain types of cancers. So a couple things that I didn't talk about. There's something called tumor-specific antigens. So tumor-specific antigens, essentially it's an antigen, so it's recognized by the body's immune system. And those can be looked at as part of diagnosis and looking at those cells, because then they can be used to aid in the diagnosis, looking for those specific antigens. An example of one is a PSA, prostate specific antigen. So in relation to prostate cancer, with some of the other, with specific antigens, you can also, they can have targeted immunotherapy as a treatment because it's very specific to that type of cancer. The tumor suppressor genes, which are genes that make a protein Normally, a tumor suppressor gene makes this protein. The protein helps to control the growth of the cells. It's when mutations start to occur in those suppressor genes that lead to cancer cells to develop, essentially. And the other piece is a proto-oncogene. So a proto-oncogene is normal cell growth. When that proto-oncogene becomes mutated, it turns into an oncogene, and an oncogene can cause cancer to grow. These are also some of the terms that are in that Quizlet, just to review what some of those things mean. There's also information about them on the cancer.gov site if you have questions about any of those specifically. Some other diagnostic tools, patients, and they may or may not be necessarily in this order. Patients can have X-rays, MRIs, CTs in order to help diagnose. Just looking to see location or size of tumor. Sometimes if the patient comes in and is reporting particular symptoms, like they're having abdominal pain, they may do a CT of the abdomen and then they could note the tumor. So aspects like that. Remember, nursing care with an MRI, it's magnetic imaging. So make sure the patient doesn't have any metal on or in them, like no pacemakers. Make sure that they've never had any type of injury where they've had metal like under the skin or in the body. With an MRI, it tends to be in a closed-in type of machine and it's loud. So for some patients that can be anxiety producing. So other nursing care for an MRI. If an open MRI is available, like if you have a patient that's claustrophobic, that would obviously be a better choice. If not, they may need some type of anti-anxiety med pre-medication before an MRI. With a CT scan, remember CT can have IV or oral contrast agents used. Assessing for allergies before. Making sure that if the patient is going to receive IV contrast, that they've not taken metformin. A PET scan, so a positron emission tomography. It can be used to look for either the spread of cancer, so they're looking to see if it's spread somewhere else within the body. It can be done in combination with the CT, or it can be done on its own. Sometimes it's also done to look at treatment, like how is the treatment working? Is it effective? So with a PET scan, there's a radionuclides that may have sugar in it, and the cells that have a high metabolism take up that radionuclide, and because they have such a high metabolism, they're essentially taking up the sugar. And then when you do the scan, there's hotspot areas that you can see. A bone scan is similar. The radio tracer that's used for a bone scan is taken up by the bone specifically, and where there's high metabolic demand shows up like as a hot spot on that bone scan, and it can indicate that there's bone metastases. So bone scans can also be done for other reasons, just like the other diagnostic tests. One thing not to mix up, a bone scan is not the same as the type of scan that's done for a patient with osteoporosis. It's not looking at bone density. A bone scan is looking for areas of high metabolic activity. So it's looking for cancers or bone infections, those type of things. And then the genetic testing can aid in that diagnosis, like we talked about. Biopsies. So biopsies are the definitive way, because we look at the actual cells based on what the cells look like and how they're tested from what we talked about at that cellular regulation, is what actually diagnoses the cancer. So there's a variety of different types of biopsies. Excisional biopsies. So if we excise something, then essentially we're removing it. So we're taking the whole thing. So an excisional biopsy removes the tumor and it removes the surrounding tissues, hopefully enough to get clear margins. So it can also be treatment related as well, because they've removed the entire tumor and the surrounding area. An incisional biopsy is done when they cut into it and take a piece of it to sample. So they don't take out the entire tumor, they just take part of it and then test it to determine if it is cancerous. A fine needle aspiration is exactly as it sounds. It's a needle aspiration, so like a needle and a syringe, and they draw off fluid or cells from the tumor. A fine needle aspiration, depending on where they're doing it, they may do it ultrasound or CT guided to ensure that accuracy. If you think about, like if there's a tumor on the lung, then we need to be very precise about where the needle goes in and make sure it hits the tumor and that we actually can get cells of that, because there's a risk putting that needle in that you could cause a lung to collapse. So they would do it ultrasound or CT guided to make sure that they're in the exact right spot for it. A core biopsy is a lot like a needle biopsy, except it's a little bit bigger sample of tissue, about 1/16 of a centimeter is taken roughly with a core biopsy. A sentinel node biopsy. So we said that one of the ways that cancer can spread is through the lymphatic system, right? So the lymphatic system, lymph nodes. Breast cancer is a common place that you'll see this, but you can see it in other cancers as well. The picture at the bottom right of this slide is a sentinel, essentially it's a sentinel node biopsy. So a sentinel node is the first nodes that the tumor would drain to. So if you're looking at this picture, there's a tumor right here, upper outer quadrant of this breast. So to do a sentinel node biopsy, they will take this dye, and it's either radioactive or a blue dye or a combination of the two, and they will inject that dye directly into that tumor. So once they inject the dye into the tumor, then that dye will travel to the lymphatic system, the first lymph nodes that that tumor would drain to, or the first lymph nodes that that tumor would spread to, is essentially what we're looking for. So typically with a sentinel node biopsy, they'll inject that dye, and then they use a probe to test and see which lymph nodes are affected. Like if it's they're radioactive, then with the probe they actually can tell which nodes the dye was taken up by, and they'll go ahead and remove those nodes. The recommendation for sentinel node biopsies is at least 2 to 3 nodes are removed. Sentinel node makes it sound like it's singular and only one node, but the recommendation is really to take 2 or 3, because if you just think about it, there's so many lymph nodes in the axillary area. If they just take out that very first node, well, if that first node comes back positive, how do I know that it didn't get into a second node or a third node? So that's why the recommendation is to take at least the first couple, because if they test 2 or 3 nodes and that first one comes back positive, but the second one doesn't, then we know that it didn't spread far. And with that sentinel node biopsy, it can be done at the same time as a surgical procedure. So like with the breast cancer, just because that's the picture in front of us, a patient could have a lumpectomy or a mastectomy and remove the cancer they do the biopsy at the same time they're doing that procedure. So they inject into the tumor and they trace it, and then they remove the tumor and remove those couple of nodes. Remember not to get confused. A sentinel node biopsy removes the entire node. It's not a needle aspiration, only removes cells from the tumor itself. Other types of biopsies, endoscopic. So an endoscopic biopsy is direct visualization of the GI tract, so through endoscopy or colonoscopy. And there's also surgical biopsies, like a laparoscopic procedure, where they can go in and remove the tumor. So once this tumor has been biopsied and it's been determined that it is malignant and actually cancer, then some of the things that are looked at. Page 370 in your med-surg book, there's a table about grading. So when they talk about grading a tumor, essentially they're looking at how different is this cell from the parent cell. Like how much change has occurred to this cell compared to where it came from or what it started out as. The higher the grade, the more aggressive the type of cancer it is. The lower the grade, the less aggressive type of cancer. So if you have anything that's an X, because a lot of these scales involve an X. So an X means it's not been determined or not been assessed. And then grade 1 through 4. So a grade 1, the tumor cells are differentiated and they're pretty similar to where they started out as. So if we're talking about lung cancer, then those cells are pretty similar to a normal lung cell if it's a lower grade, like a grade 1. If it's a grade 4, then it's going to be that they're very poorly differentiated, or they don't have anything, they don't look anything like the original cells that they came from. So the big thing to take away is the higher the number, the more aggressive the treatment is going to be. As far as where the patient goes from here. We're not grading cancer and we're not staging it because that's not within our scope of practice. It's just more, what do we know about this? If a patient has a high grade tumor, then that's a more aggressive type of tumor. They're probably going to have to undergo more treatment, maybe more aggressive types of treatment. And then there's the TNM, so tumor node metastases staging system. There's on that same page 370 in your book, there's a chart that goes through the different categories. So it looks at the tumor itself. It looks to see whether or not there's lymph node involvement. And it looks to see if there's metastatic disease. So anything that is an X has not been or can't be assessed. So for example, an NX would mean for lymph nodes that no diagnostic test was done to determine if lymph nodes were involved. So yeah, we tested the cells, we tested the tumor, but they didn't test the lymph nodes. So that would be an NX, for example. Anything that is a 0, because this scale goes X first, then 0, there's no evidence of it. So with a tumor, there's no evidence, a T0, there's no evidence of a tumor. An N0, then there's no lymph node involvement. And an M0, there's no metastatic disease. The tumor system then goes 1 through 4 based on the size or extent of the tumor. There are subcategories within that. There are certain types of cancers that there may be a T2, so it's tumor stage 2A, T2B, like it may be broken down even more than that for certain types of cancers. Again, you don't need to know all of the specifics of that. The big thing to remember is in looking at this, like if you have a TNM and you have numbers next to it, then the lower the number, the better the prognosis. If there's not node or metastatic involvement, the easier it's going to be to treat, because they can a lot of times just resect the tumor, or you only have to treat the tumor. You don't have to worry about the fact of it spreading to other places. So look at it more like we did with the grading. The lower the number, the better the prognosis is for the patient. The higher the number doesn't necessarily mean the prognosis is always bad. It just means that the treatment might be different. Specific examples, if you look on the cancer.org website, so the American Cancer Society, if you pick a type of cancer that's listed on there, colon cancer, breast cancer, and if you look at the treatment section of it, there's information about specific treatment recommendations for a patient that has stage 3 colon cancer versus somebody that has stage 2 colon cancer. So that's what they're looking at with some of the staging. So our patient's been diagnosed with cancer. Our patient has probably going to have more than just one healthcare provider. So who else is involved in the care of this patient once they've been diagnosed? There's a whole host of people that can be involved. The patient's going to have an oncologist to focus on their cancer. The patient may have a variety of types of oncologists. They may have a surgical oncologist. They may have a radiation oncologist, depending on their treatment. They are very likely to have an oncology navigator. So an oncology navigator could be a nurse, or it could be a health navigator that essentially helps the patient navigate the healthcare system. That there are a lot of appointments, there's a lot of follow-up, that this person helps them to navigate through the healthcare system to make sure that they understand and are getting the treatment that they need. There's navigators for a variety of different types of healthcare disorders. Oncology navigators were probably one of the first ones that was started, and they really are beneficial to the patient in the long run. The patient may have a mental health healthcare professional, or like a mental health counselor, if there's anxiety or stress, or just somebody to talk to in regards to the diagnosis. Palliative care is often part of the collaborative care. So palliative care is focused on quality of life. It's not, don't think, because a lot of names are like hospice and palliative care, that they're one and the same. They are not. Palliative care is typically started early for patients with a cancer diagnosis. They're there to help them with the quality of life. It doesn't necessarily mean they're going to die or that they're headed for hospice just because they have a palliative care consult. There's a lot of services that they can offer to help the patient and their support system. So depending on the location of cancer and the type of treatment, PT, OT, speech could all be involved in the care. Infusion care, which you'll get to see as part of your clinical rotations. You may see patients that are receiving treatment for different types of cancers. And then there's various support groups that are available to patients, other patients that have been in their same or similar situations. Somebody that's lived through it and has experience can be very beneficial to the patients. The American Cancer Society has a ton of information available about support. They have a lot of good patient resources on there that you can refer patients to. Pain associated with cancer. So there tends to be some myths and some misconceptions in regards to cancer and pain management or having pain. Some patients feel like, well, I was diagnosed with cancer. The doctor should know that I have pain. Well, we're not mind readers, so that's not necessarily a true statement. Remember, pain is subjective. It is what the patient says that it is. So the big thing is to encourage discussion about it, asking the patient how they're feeling, encouraging them, if they are having pain, to talk to their healthcare provider about it. We can always provide information about alternative options that may be beneficial, some type of pain management regimen. Some patients, another myth, think that pharmacological intervention is the only available treatment for cancer-associated pain. That is not a true statement either. There are a lot of non-pharmacological options available to patients. Physical therapy can be beneficial, acupuncture, guided imagery, relaxation techniques, meditation, music therapy, massage, hot or cold compresses, nerve stimulation for nerve-related pain. So there's a lot of things that we can do that aren't just, here, have some more pain medication. Some patients are afraid of tolerance or addiction, that, well, if I start taking pain medicine for my cancer pain, then I'm going to become addicted. Not necessarily a true statement. It is rare that cancer patients become addicted to pain medication, that they are, if they work with their healthcare provider for an individualized plan of care to manage their pain, then they're far less likely to become addicted. It is possible that they do develop a tolerance to pain medication, that if you are taking pain medication, that over time your body can build up a tolerance and the dose might have to be adjusted or the medication adjusted. But if they keep that communication open with their healthcare provider, then coming up with what works best for them is a lot easier to do. More than half of the patients who are receiving treatment for cancer will develop pain, and about 2/3 of the patients who have advanced metastatic disease will have severe cancer pain. So trying to find ways to help them adequately control it is best. If patients are prescribed analgesics for the pain, then oral is the preferred route, especially initially, and scheduled pain medicine. So round the clock, not just PRN when they need it. They have a little bit in their system all the time. It will help to manage that pain more effectively. There's 2 links down here at the bottom that are just to a couple short handouts on cancer-related pain. And there's like a kind of like a stair-stepping guide as to pharmacological recommendations. Like initially, we don't jump right to narcotics first, that we start out with something, maybe something over the counter or non-opioid, and then we progress up based on the patient's tolerance or the patient's level of pain. So there's 3 primary treatments for cancer: surgery, radiation, and chemotherapy. This is where we're going to spend more time focusing. These treatments can be used individually or they can be used in combination. 2 of them or even all 3 of them. It's all going to vary based on the specific patient. So we're not going to go in great depth about surgery because we have a whole unit on perioperative care and nursing later on. Just some different types of surgeries that can be done in relation to a cancer diagnosis. Prophylactic surgery is surgery that would be done prior to a diagnosis, like somebody that's high risk or somebody that's had positive genetic testing and they prophylactically have surgery. The easiest one is related to breast cancer, like a woman who has a mastectomy prophylactically because she's at such high risk for breast cancer. Diagnostic surgery is like what we talked about a couple slides ago with the biopsies, where they could have a surgical biopsy, like a laparoscopic procedure. So go in and remove some of the tumor or all of the tumor and to diagnose cancer. There's curative surgery for like a localized tumor. They go in, remove the entire tumor. Debulking is to debulk part of the tumor. So if they can't remove the entire thing, but they can remove part of it in order to help with symptom management, then that would be like a debulking procedure. Palliative is to help increase quality of life. So a debulking procedure could be a palliative procedure that we can't cure the cancer maybe, but we could get rid of some of the tumor and it will help cut down on the symptoms that the patient may be having. An example would be like a patient who has maybe a large colon mass that can't be completely removed. And because of that, they're having a lot of GI related symptoms or a lot of obstructions, abdominal pain, that if they can go in and debulk and remove part of that tumor, it would help decrease their symptoms, maybe decrease that likelihood of an obstruction. So it would be a palliative procedure. And then reconstructive is typically what's done after the cancer. Either it can be done as part of the treatment or it can be done after the fact. So like reconstructive breast surgery after a mastectomy or a skin graft after treatment for skin cancer. Those would be examples of reconstructive surgeries. Radiation. So with radiation, there's a couple different ways that radiation can be administered to our patients. This aspect of nursing care moves into chapter 20 of your med-surg book. So with radiation, there is external radiation, there is internal radiation, which is also called brachytherapy, and then some radiation can be administered ingestion. We'll talk more about the ingested form of radiation, like when we talk about thyroid disorders, because that's a common place that one is used. So with radiation, radiation therapy will determine the dosing and all of that. There's high dosing, there's low dosing based on the type of radiation, the type of cancer, the location of it, a lot of other factors. Dosing can be adjusted based on the patient. Big things we need to know, precautions. So do we want everybody exposed to radiation? No. So which patients are we most concerned about taking specific precautions with? So if a patient undergoes external radiation is like external beam radiation. So the patient goes to radiation therapy. They have a marking typically put on the skin where the radiation needs to be specifically directed, and that radiation is delivered in a matter of a couple of minutes to the patient, and then the patient leaves. So there's not really any specific precautions to take, except if you're working in radiation therapy and you're there while they're receiving it. When that patient walks out of radiation therapy department, they're not radioactive. They're not carrying any type of risk to any other patient or family member. And typically with external radiation, it's a very short time frame. So they go in, they receive their radiation. They have to typically have so many treatments. If they go 5 days a week, they may go for 4 weeks or 6 weeks. It all just depends on the specific patient. With internal radiation, so the radiation is placed internally within the body. Some examples, it can be done with, when we talk about prostate cancer, seeds, radiation seeds can be implanted into the prostate. It can be done with breast cancer, lung cancer. There's a variety of different where seeds or pellets are put internally. Some of them are put in and left in. Some of them are put in and then taken back out. So while those seeds are in place at certain times, those are the patients we need to take precautions with. That patient, if their seeds are in place, like for example, the prostate cancer and the prostate seeding, that patient is radioactive while they have those seeds in place. Is it likely that they're emitting radiation to everybody that comes close to them? No, because of the dosing of that radiation, but we still take precautions. So those precautions are time, distance, and appropriate shielding. So your textbook talks about this on page 379. So time is the length of time that we're exposed to it. So if you are taking care of a patient who has internal radiation, then we want to try to limit the amount of time that we spend with that patient. So you need to be organized. You need to be able to, like when you go in that room, you go in, you do your assessment, you give them their med, and you come back out. You can't stay in there for excess amounts of time. Usually 20 to 30 minutes max, and you really want to limit that throughout your shift. And then distance, typically the recommendation is usually to try to stay about 6 feet from the patient. Can I do your assessment and be 6 feet away? No, so obviously you're going to have to get a little bit closer for some things, but then that's where the time factor really comes in and is important. The shielding, it really depends on the type of radiation that the patient has. Like I've taken care of a lot of prostate seeding patients. I've never worn shielding. Like we don't walk around our 12-hour shift wearing a lead apron to take care of that patient because of the radiation. Now, if you're working on like a radiation oncology unit and you have a lot of patients that have different dosing or where there's a lot more exposure, then they may take more shielding precautions just because it might be with every patient and there's more risk. The other thing that you may see is dosimeter badges. So the dosimeter badges are like what are worn for like a radiology tech a lot of times, or those people that work within radiation therapy will wear a dosimeter badge to determine how much radiation they've been exposed to. So let's talk about some side effects. So external radiation is the beam radiation. The patient comes in for their few minutes, they get their radiation. Their site has been marked, so it's pretty specific. So if they're trying to radiate a lung tumor, then they know exactly where to aim it, and it's aimed specifically at that tumor. However, that radiation can still have localized effects. Most patients who have any type of external radiation have radiation fatigue. It's a very common symptom that's associated with radiation in general. The other big localized effect is skin. So wherever the radiation is targeted, that skin can become damaged. It can be anything from irritation to redness to where the skin is actually starting to break down and it may be open. So it really just depends on the extent of the radiation and on the particular patient. So skincare is really important. In your textbook on page 382, there is a chart that covers the skin protection during radiation therapy and what should be done to help protect that skin. So loose fitting cotton clothing if the skin is irritated. Do not put anything on that skin that's not been prescribed or recommended by the physician or the radiation technician. Like they may give you specific creams or things to put on the area. Over-the-counter soaps tend to be very drying, so they'll usually tell them to just use warm water and then maybe pat the area depending on how bad the skin irritation is. Don't put anything tight over it. Don't rub the area. If it is an area that can receive sun, then it should be protected from the sun if they go outside, like keep it covered. Other side effects related to external radiation are going to be based on the specific area. So for example, that if we're radiating a lung, say, we'll say the patient has bronchial cancer. So think about where that would be. So lung cancer, and it's up near the bronchioles. That radiation is very targeted. Well, what is close to there? The esophagus. So the patient could have difficulty swallowing or have GI related symptoms because that radiation, yes, it's hitting that tumor in the lung, but it's also hitting what's right nearby or in that direct path. So there's also risks of side effects related to that. If the patient's receiving radiation for their lung, then are they likely to have diarrhea as a side effect from radiation? No. But if they're receiving radiation for colon cancer, then yes, they might have diarrhea because of where it's targeted. So it's based on the specific area of the body. There is a chart on page 381 that talks about some of the side effects that can occur based on where it's being aimed at. So like the GI symptoms are going to be more abdominal cancers. So GI, GU, if radiation is targeted there, then you're more likely to see side effects related to that area. If you're having head and neck radiation, then you might see the irritation, the mucositis, the irritation to the oral mucous membranes, or the xerostomia, which is the dry mouth. So just remember that with external radiation, it's targeted. So it's going to be specific to the area in which it's going. Internal radiation, oh, maybe I got ahead of myself a little bit before. This is where we take our precautions. This is where the patient may have something implanted, a seed, a rod, and it's put directly in the tumor. Or it can be given the IV or ingested route. So because this is the one where the patient does have that radiation, then there is risk to those around them. So this is where we take our precautions, our time, our distance, our shielding. This one has one of those a QSIN chart with some of the nursing care related to internal radiation. The patient needs to be in a private room. We don't want to be radiating other patients because they're sharing a room. We keep the door closed, the dosimeter badge, if based on the facility and the specific unit, no pregnant staff members and no pregnant visitors, no small children should be allowed in the room. Based on, there's usually some type of radiation precaution sign that goes on the door. And then that room has to be cleared once that patient is discharged. So like I've taken care of a lot of prostate seeding patients that while the patient is in the hospital, the linen that's in the room stays in the room. Like we don't take out that linen bag while the patient's there. The food trays can go in and typically can come out, but any type of linen stays within that room until the patient's discharged. Most of the time, those patients are only in the hospital overnight. So once that patient's discharged, that room is marked off until somebody from radiation therapy clears that room to ensure that there's no radiation anywhere within it that anybody could be exposed to. Then once the room has been cleared, then you can remove like the linen from the room. We'll talk specifically about some of the internal radiation types, like when we talk about prostate cancer and when we talk about breast cancer, we'll go a little more in depth, and with some of the GYN cancers where you might see it. I think I have a link to some to a website with some examples of the internal radiation. So I'll try to post those in the discussion forum, just so you have an idea of how it works. So chemotherapy, with chemotherapy, the medication is given, which helps to destroy the cancer. Chemo can be given a variety of different routes. So based on how it's given, can sometimes affects some of the side effects that we might see. Chemo can be given orally. IV is a very common route. It can be given intravesically, which is like it can be put directly into the bladder. It can be done topically, like for skin cancer. Patients could have topical chemotherapy that's used. It can also be done different cavities within the body, so intraperitoneal or intrathecal. So just different areas of the body based on where the tumor is. It could be put directly into there. Because chemo is more systemic than radiation, like when we talked about radiation, the side effects of radiation are localized. So it's whatever specific area is being radiated, whether it was external radiation or internal, it was just whatever was close by that was typically affected for side effects. With chemo, because it tends to be systemic, it affects rapidly dividing cells. So common areas that it can affect are the bone marrow, the GI tract, the hair, and the, well, as part of the GI tract orally. So that's why the side effects, that's why there tends to be so many more side effects with chemo compared to with some of the radiation. Chemo can be given before radiation or before surgery, or it can be given after radiation or after surgery, just depending on the patient and the need based on their cancer as to when they receive it. We do not cover any of the specific chemo drugs. So there is a specific chart in your book about chemo meds, like that gives actual names. You don't need to know the names of the meds because who can give chemo? Nurses can give chemo, but they have to be specially trained in order to be able to give chemo. I can't give chemo. You have to be, the nurses that you see at Infusion Care, if they are certified or they've been specifically trained, then they can administer chemo. I can take care of a patient who's receiving chemo because somebody that's certified initiates that, and then I can monitor and assess them while they're receiving it. Some of you maybe that have been on like One North for clinical at Iredell, you could have seen patients that are in the hospital to receive their chemo, and that chemo certified nurse initially starts the infusion, but if it has to run over a 24-hour period, then that primary nurse does the continual assessment of the patient. So some big things, chemotherapy, because it kills all of those cells and those rapidly dividing cells, blood cells are big. Let's go to the next slide. So pancytopenia. Pancytopenia is, penia is low, so pancytopenia is low red blood cells, white blood cells, and platelets. So the three big cells that are produced in the bone marrow. So page 387, I believe, talks a little bit about it. And then some normal values. So a normal, there is a chart in your textbook that has normal values on it. I will add it to the notes section of this slide so that you know exactly where to find them within the textbook. So a normal white blood cell count, your med surg book says 5 to 10,000. You may hear 4.5 to 10.5 or 4 to 10, somewhere in that range would be considered normal. So if we're worried about pancytopenia, then we're worried about that count being low. so less than. Anemia, so red blood cell count that is low, so normal red blood cells. I'm not sure if how much you've been taught, so if this is a review, then you can skip this a little bit. But red blood cells, hemoglobin and hematocrit, so part of your CBC. So normal red blood cell count is usually around 4 to 5. I don't know if you know about the rule of threes. So if you take your red blood cell count and you multiply it by 3, then that gives you your hemoglobin. If you multiply that by 3, then that gives you your hematocrit. Roughly, it's not always 100%, but pretty close. So if you have a red blood cell count of 4 times 3 would be 12. So 12 for hemoglobin, and then 36 for a hematocrit. So if you can't always remember all of the normals for red blood cell, hemoglobin, hematocrit, if you know one of them, if you can remember that rule of threes, it can kind of help you to figure it out. Like I tend to know normal hemoglobin the most. So if you give me a red blood cell count, if I'm not sure if that's normal or not, like I'll multiply it by 3 to get what my hemoglobin roughly would be. And then I can usually tell you if it's low or it's high. And then a normal platelet count, 150 to 400 or 150,000 to 400,000, depending on the units of measure. So with pancytopenia, I'm looking for the low end of those to all be, I'm looking for those to all be below the low end of them. So that white count less than 4,000, a red blood cell count less than 4, and a platelet count less than 150. The lower they go, the higher the risk. For example, with that platelet count, so if the low end of normal is 150, the lower the number of platelets, the more at risk the patient's going to be to bleed. Once you reach a platelet count of less than 50,000, the patient's going to have prolonged bleeding. If you get to a platelet count of less than 20,000, the patient's likely to have spontaneous bleeding. So the big risk, low platelets, is thrombocytopenia and that risk for bleeding. Low white blood cells, then there's a big risk for infection. Within the low white blood cells, we also look at neutrophils. I know you really don't have a lot about a differential, and you'll get into that more later on, but neutrophils typically make up around 70%, 60 to 70%, I believe, of the white blood cell count. So if your white blood cell count is 4,000, then about 2,400 would be where we would expect the neutrophils to be. So as the neutrophil count or absolute neutrophil count drops below 1,500, then the risk for infection goes up significantly. So a neutrophil count less than 1,500, there's a pretty good risk for infection. You get less than 1,000 and that risk for infection's even higher. If you get less than 500 neutrophil count, then the risk for infection is extremely high. So neutropenic is how that is termed based on the level. And then the, so some of the nursing care associated with that. If you look in your med-surg book on page 388, it specifically talks about prevention of infection. So the prevention of infection is going to be huge for those patients that are pancytopenic, and they have a low white blood cell count and a low neutrophil count. They need to avoid people that are sick, large crowds. You need to teach them good hand washing. They should not have fresh flowers. They should not drink. They should be really cautious about what they drink if it's been standing. Like, we don't want them to drink a cup of water that's been sitting in their room all day because there could be bacteria in it and their risk for infection is so high. Teach them to watch out for signs and symptoms of infection, because chemo is destroying those cells. It's killing the good cells too. So it's decreasing their immune system. If we're decreasing their immune system, they're going to have a hard time developing symptoms. Like if you or I get sick, then we get a fever because that's our body's normal response to some type of infection or being sick. Somebody that's immune system is compromised or being suppressed because of these medications is going to have a harder time doing that. So when that happens, if they start to get a low grade temp, 100.4, the recommendation from your textbook is 100.4, then we start to get concerned because their body had to work hard to produce that fever. So it probably means they have some underlying infection. So we need to be cautious of that. Make sure that they watch out for any other signs of infection, like any wounds that aren't healing, foul smelling drainage, if they have sputum or a cough. So just any type of infection. One of the things that some people may have heard is patients who are high risk for infection on chemo to avoid fruits and vegetables. It's not avoidance of them. Patients should make sure they use safe food handling practices. So wash your fruit before you eat it. Don't just buy your fruit and eat it. Like, especially if you're eating something that like a strawberry where you eat the whole thing, or like an apple where you eat the skin, because if it's not been adequately cleaned, then there could be bacteria on it and there's a risk for infection. So it's really just raw. With raw produce, they need to just make sure that it's been appropriately cleaned before they eat it. The other part of that, nursing care, so those were our infection risks. With the platelets, the risk was for bleeding. So prevention of that, there's a chart on page 389 of your med-surg book. So low platelet count means there's an increased risk to bleed. So we need to teach the patient to be cautious. No straight edge razors, like they should be using electric razors. They should watch out for any type of activity that could cause bruising, like contact sports or activity. They usually are not taking any type of aspirin or antiplatelet or anticoagulant because their count is already so low. They have to be cautious with brushing their teeth, flossing their teeth. They shouldn't, if they're not a tooth flosser already, then now is not the time to start, because you're likely to have bleeding of the gums. And if their platelet count is low, then they're at high risk for that. They should use a soft toothbrush in order to prevent trauma to their gums. Avoid anything rectal. So no rectal temperatures, no rectal suppositories, because there's a risk for bleeding. There's also a risk for infection because of that trauma. So that one's kind of twofold. They should watch for signs of excessive bruising. They may need to take a stool softener or something to help them have a bowel movement so that they don't strain, because again, they're at high risk. If they strain, they're at high risk to bleed. So I would review that, both of those charts that I mentioned. The next one is chemotherapy-induced nausea and vomiting. So it's not just that we have nausea and vomiting, it's specifically linked to the chemotherapy and the drugs that are used for it. There is a variety of meds that are listed. Some of them you should have heard or learned about, like some ondansetron, which is Zofran, that can be given to help with the nausea. These patients tend to be pre-medicated. So if they're going to receive chemo, oftentimes they're pre-medicated to help decrease that risk of nausea. Dexamethasone is used. to help pre-medicate for nausea. They may have some of the other serotonin antagonist, which is the Zofran, ondansetron, or granzetron, is another one within that category that can be given. Reglan or metoclopramide could be given as well to help with the nausea and vomiting. Patients that do have nausea from chemo, smaller meals may be beneficial. Avoid foul smelling foods because that may contribute to their nauseous feeling. The antiemetics we've already talked about. If there's some patients, ginger or ginger ale may be helpful for nausea and vomiting. Some patients I've heard peppermint can be beneficial too. So it's kind of a matter of figuring out what may help them the most with their nausea symptoms and what's going to help them get the best nutrition that they can, because the nutrition aspect of it is important. So preventing the nausea and vomiting, but then also maintaining their nutrition. Alopecia can occur with chemotherapy. Alopecia is hair loss. So with chemo, oftentimes alopecia occurs with certain medications. Certain chemotherapy medications are more likely to cause alopecia. Some patients will lose their hair, others will not. Some of the things that can be done, there is newer treatment options with something scalp cooling, where they like put this cooling cap on, and because it's cool, it decreases the blood flow. Therefore, the chemo meds do not get to the hair as much, hair follicles as much, so they're less likely to lose their hair. There's information about wigs or hats or scarves that can be used. So anything to try to help them with the body image aspect of it. If they do have alopecia, make sure they know to protect their head. So if they do go outside, then they should have a hat or scarf, something over it, avoid the sunlight so that it doesn't cause damage to their head and that tissue. Another side effect of chemo is mucositis. So that is inflammation that affects the oral mucosa. You may hear mucositis, you may hear stomatitis in relation to that, but there's inflammation in the GI tract and oral mucosa. So big things to watch for with that. Again, there's another chart I would recommend you look at, page 391 of your med-surg book. With these patients, making sure they have good mouth care so that they brush their teeth after each meal, more than a soft toothbrush or even the sponges, but just to keep the food and the bacteria out. Avoid over-the-counter mouthwashes because most of them have alcohol in them and that's going to burn. Bland foods tend to be less irritating. Maybe using a warm water or a warm salt water rinse can help. If they can increase their fluid intake, they may be prescribed specific or prescribed mouthwashes. Like there's a Miracle mouthwash or Magic mouthwash that has a combination of things in it that may have some benefit for some patients. There's not really a whole lot that is specifically proven for that. If they do get bacteria or they start to get like thrush, then they could be prescribed like a mycostatin or something like that to swish and swallow with. avoid any foods that are going to be irritating. So acidic foods, spicy foods, extreme temperatures are going to be more irritating to their mouth. Cognitive changes can occur as a side effect of chemo. Sometimes it's referred to as chemo brain. A lot of patients report having cognitive changes after they've received chemotherapy. The big thing for this is making sure that the patient is aware that it might occur, and allowing them to talk about it and see what kind of changes they're having. And then kind of like if they're having trouble remembering things, then are there strategies we can try to give them to help them to remember, or they may, depending on the extent of it, there is like cognitive training or therapy that can be done if needed, if it's that severe. For most patients, it tends to be more of a mild impairment, and it may improve after treatment. For others, it may last for a long time after treatment. It really is specific to the patient. And the last big side effect is chemo-induced peripheral neuropathy. So we'll talk more about peripheral neuropathy in some upcoming units. But essentially, peripheral nerves, we're talking about the pain associated because of those nerves and the irritation of them. Some of the medications specifically damage those nerves. So when that happens, patients may have numbness, tingling, burning, pain, loss of sensation in those peripheral nerves. So if it is lower extremity, then it could affect their balance or their walking. If it's other areas of the body, then it may have different effects or sensations. Fine motor skills could be affected. There's not necessarily specific things that are done in order to prevent it per se. It's more what can be done to prevent complications from it. Like making sure they're aware, no excessive heat, no excessive cold, because it might cause damage to the tissues. There is a chart again on page 392 about some specific patient education in regards to peripheral neuropathy. The extreme temperatures, watching out for your feet is big, and we'll talk about that in relation to diabetes in an upcoming unit as well. But because they can't feel, they may not realize that there is damage. If they're having sensation issues, then they may need ambulation aids, or to look down, watch their feet when they're walking. If they can't feel them, then they need to see what they're stepping on. Be cautious for falls risks, because they're going to be higher risk for falling. A couple other side effects in regards to chemo that I didn't mention or that aren't specific on here, just some general things. Chemo overall can decrease bone density, so it puts patients at higher risk for osteoporosis. It can cause cardiac muscle damage and hemorrhagic cystitis, so it can cause bleeding, urinary cystitis. With some of those, there are certain medications that can be given to help protect from some of those side effects occurring. So it's really something the oncologist would determine based on the type of medication that the patient's receiving, like which ones are more likely to cause some of these things. Some additional treatment options that are available to patients. Immunotherapy. So immunotherapy essentially works off the body's own immune system to help fight the cancer. And an example of that is like what I talked about with the specific medications that are targeted based on the type of cancer cells or the genetics of it. There's monoclonal antibody therapy that is targeted therapy that can be used for those specific antigens that I mentioned, which is, again, targeted therapy. It helps to stop that growth or the spread of the cancer. Again, certain drugs are targeted based on how they work and the specific aspects of the patient's cancer cells. There's hormonal therapy, which falls under that endocrine therapy. So the cancers that are reproductive related or that may be linked to hormones, then those would be treated with endocrine therapy. When we talk specifically about like breast cancer and prostate cancer, then we talk more about some of those endocrine therapy ones because those specific meds are targeted based on that hormonal role. So there's a whole section in this chapter on immunotherapy and those things that I mentioned on here that we're not going to go in depth on. Just know that they are available treatment options for patients aside from the traditional ones. And some of these things are where you would see like the clinical trials that are going on and newer options that are coming into practice. There are 4 oncologic emergencies that we're going to talk about. The 4 that are listed on this slide. Your textbook also lists a couple others, and there's a note at the bottom of this slide. We are not discussing sepsis, DIC, or SIADH, so you can skip right over that section. These 4 are the 4 we're going to briefly talk about. I have an article that I will post for you to review. I believe it's a little bit older of an article, but the information in it is still accurate and it's written at a pretty simplified level just to help you to understand it the best. So spinal cord compression is exactly what it sounds like, that there is a tumor or something pressing on the spinal cord itself. So the symptoms are likely to be related to those nerves. It could be from metastatic disease, like if there's metastatic disease in the spine, then it can cause compression on the spinal cord or the nerves as they're coming out of the spinal cord. Treatment could be radiation in order to help to decrease some of that pressure. Hypercalcemia, so you should have talked about hypercalcemia and fluid and electrolytes with Ms. Carly. Essentially, the calcium gets released from the bone, so then it builds up in the bloodstream. You can see it with metastatic cancer to the bone and also some of the myelomas. So if you just pull back in what you know about signs and symptoms of hypercalcemia, patients may have bone pain, they may be lethargic, confused. So treatment-wise, it's going to be the same treatments that you saw or that you talked about in the electrolyte unit to help return that calcium back into the bone to decrease it from the serum levels. So the biphosphonates, the zoledronic acid, possibly some diuretics. Superior vena cava syndrome is where there is a compression on the vena cava. So if the vena cava, there's a lot of lymph nodes that are near the vena cava. So if cancer gets into those lymph nodes, then that can cause superior vena cava syndrome. Essentially, think about what the vena cava does. It returns the blood from the head and the neck down to the heart. So if we obstruct that or compress that vena cava, then what's going to happen? the patient is going to have, there's a good picture of what it would look like on page 398 if you're a visual person. Swelling, face and neck, because there's a backup of all of that. Blood where it can't come down. They may have shortness of breath. They may have level of consciousness changes, and that's really because there's increased pressure, increased intracranial pressure, because it can't come back down. They could end up with stridor, in addition to the shortness of breath or the dyspnea. Typically, superior vena cava syndrome is treated with either high-dose radiation. Sometimes steroids can be given to try to help to decrease, or chemo could be given. Tumor lysis syndrome typically is a result of chemotherapy. So it essentially causes the cells to lyse, so it causes the cells to break apart. Well, when those cells break apart, it shifts the electrolytes. So as the electrolytes shift, some of the big electrolytes that you've learned about become an issue. Potassium tends to increase. So hyperkalemia, big things I worry about with hyperkalemia is cardiac issues. So think about how you would treat if they have hyperkalemia. They can also have increase in phosphate. If phosphate is going up, then calcium is going to go down. They can have an increase in uric acid. And it can lead to renal issues and acute kidney injury. We're not going in depth in that path though. Focus more on the aspect of the electrolytes. And if there's a buildup of uric acid, then think back to what you can do to treat increased uric acid. And then from gout and from pharmacology, as far as the other electrolytes, go back and review what's done to treat the hyperkalemia, because that's really the biggest one that I'm worried about, just because of all the cardiac risks. And the last bit that we will talk about is cancer survivorship. So cancer survivorship is become more of an issue now that there are so many patients who are living past their cancer. It's been treated, they've gone into remission. So now what happens? How do I return to normal life? Because cancer has determined their whole life course throughout the treatment phase, or diagnosis and treatment. So now what do? So cancer survivorship, there's a lot of new information about it. This is where those oncology navigators may come in to help keep up with that follow-up. There are, to make sure that the appointments are being met, that the patient is receiving the recommended screenings. Now that they've had cancer, I'm at high risk to get it again or for it to recur. So are they undergoing screenings like they should? Have they changed any habits? Are there any long-term side effects from either the cancer itself or from the treatment? There's survivorship info. There's a link on the bottom of this slide for some. And then the National Cancer Institute and the American Cancer Society both have like a whole survivorship care section that's a great resource for patients as well. Because there is sometimes issues with quality of life after cancer and moving on and going back to normal without cancer dictating everything within their life. And then the aspect of another type of cancer or recurrence of the cancer they had. So it's just the support and education moving forward from this point. And encourage the patient to talk about it, ask questions. There is one thing that I forgot to discuss that was in your book right before oncologic emergencies. There's a little section on colony stimulating factors. So remember how we talked about that pancytopenia that can occur and that low white blood cell count and that high risk for infection? So colony stimulating factors are to help enhance that bone marrow. So there's a list of a couple meds on page 396. This is like your Neupogen or Neulasta, if you've seen the commercials. It's filgrastim or pegfilgrastim or sargramostim. But they essentially help treat chemotherapy-induced neutropenia. So when that white blood cell count drops so low, we have to provide them with this medication to stimulate new neutrophil production. There are also some erythropoietin stimulating agents, which I think Ms. Curley will talk to you about in relation to anemias. There are 2 that are specifically approved for cancer patients, but it just depends on the patient and their risk and how symptomatic they are, as to if the red blood cell stimulating ones are given. More commonly, you tend to see the colony stimulating ones, which are the ones that increase the white blood cell and neutrophil production. If you have any questions related to the content, then use the Unit 3 discussion forum, or you can email me and let me know.